Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Okay, we are back for a part 2 on fatigue. We are going to do a deeper dive into other treatment strategies, interventions that you can do with your patients, things to look for. We're going to touch on some mitochondria. I can't wait. Let's dive in.
So next I wanted to talk about some sort of comorbid medical conditions that you want to think about if someone's having fatigue. So obviously mood disorders, so depression, anxiety can contribute to fatigue. Of course, we think of depression, but anxiety too, if you're, I didn't really make this connection also to the last couple of years until I was studying more sort of brain retraining programs, but you can make yourself physically tired from worrying. So it's important, even if you're physically not actually tired. I know it's shocking, everything's connected, so we can make ourselves tired with our thought pattern. So just something to think about when someone who has anxiety.
Anxiety uses so much brain energy.
Yeah.
Cortisol.
So, oh my
it's
God.
Just like you're living on cortisol.
Yeah.
Unfortunately.
Yeah.
It's an awful thing to deal with.
Yeah. And then other things, of course, sleep apnea we think about. So when you do your sleep history, asking about snoring, does their spouse notice that they're stop having, apneic episodes in the night? You can have sleep apnea even if you don't meet some of the old questionnaire, sort of the old stop bang type questionnaires that we would do.
Yep.
There's a whole spectrum of conditions, including upper airway resistance syndrome, where actually thin females can have it.
Yeah.
And it has to do more with the airway than sort of different criteria than what we think of as a typical person with sleep apnea.
Smaller sinus passages. I had a sleep study because of my small sinuses, and I learned from that sleep medicine doctor that there's a correlation with PCOS.
Interesting.
Oh,
Something
wow.
like 6 times more likely to have sleep apnea if you have PCOS.
Spoiler alert, PCOS episode coming in the future.
20-part series.
Oh, yeah.
What is important to know is honestly thin women. Like that is,
It's
was so
smaller
surprising.
framed women.
Yeah.
It's female bodies that have smaller frames. It's not necessarily body weight associated.
I have these patients that are siblings, and none of them fit the characteristic of having sleep apnea, and all of them had terrible fatigue, and I did all of the things, and then it turned out that it was an upper airway respiratory disorder.
Yeah, so restrictive versus obstructive.
Yeah.
Yeah.
So
if someone grinds their teeth, is a mouth breather, tends to have like a smaller oropharyngeal passageway, smaller sinuses, like Rebecca said, maybe consider a sleep study, even though they are not fun to do, to see. And you want to make sure that the sleep specialist you're sending to is testing for UARS and not just sleep apnea, because not everyone does.
The important thing to know about sleep studies is the at-home study is significantly less sensitive than
but
the
you have
in-person.
to do it because of insurance, and then they'll set you up with the in-house one, which is equally annoying.
Probably more annoying, honestly, to be honest.
They were both bad.
Were they?
I think they've made the at-home ones with, like, I describe it as like a metal octopus you're going to be sleeping with.
With the at-home one?
But I think since then they've made it where fewer things are hooked to you.
Yeah, I think I had a nurse once explain it to me as like spaghetti. There's just spaghetti coming out of all your orifices.
So
you're not going to sleep great anyway, but somehow they can get enough data to tell us what's going on.
They give you drugs. They offer you drugs for it.
Oh, do they?
Drugs for everything. Yep.
And
Welcome to America.
Yeah, I don't know how much of an effect that has on the outcome, but obviously they can interpret the results still. So.
Yep.
And then other concurrent conditions like autoimmune diseases, heart disease, lung disease, those types of things can contribute to fatigue, of course. And then lab workup, I think we all do pretty much this standard workup: thyroid, comprehensive metabolic panel, CBC, B12, ferritin, vitamin D if it's covered.
So maybe we should dive into nutritional deficiencies.
Yeah, we could do that. And then the last part of the lab workup I'll mention is just I always check the anti-gliadin antibodies, and I think you two do as well a lot of times, just because we've had patients that just had fatigue as their main presenting symptom when they're having like a celiac type presentation.
I will say that a lot of my chief complaints are fatigue and some kind of GI thing because it's my practice.
Right.
But nutritional deficiencies, especially in the context of autoimmune disease, especially in the context of GI-based autoimmune diseases like inflammatory bowel disease, even microscopic colitis, because they're having such increased transit time. You know, small intestine is still functioning, but large intestine is everything's going right through them, can absolutely present with nutritional deficiencies.
Yeah.
And then, so that's the autoimmune, but then there's also the functional GI disorders that will also have mineral nutrient deficiencies because, again, things are going through them very quickly.
Yeah.
Or the enzymes aren't working properly.
Yeah, if small bowel is compromised for whatever reason, the enterocytes aren't healthy, they're not going to absorb well.
So I think that's why some of our patients have had amazing results when we send them for IV nutrients, whereas others feel no different. So that can kind of help with diagnosing whether it's a nutrient-related fatigue.
And again, you said it, but a shout out to ferritin. Like, check your patient's
Right.
ferritin, especially if they have a regular menstrual cycle
Right.
or have recently hemorrhaged because of miscarriage or something like that. That I find low all the time. And
Right.
I think it makes us look magic because we fix it and they feel amazing.
Low is so difficult to pinpoint, though, in my experience.
Yeah.
Because depending on what data set you're looking at,
Yeah.
low has very different definitions.
Yep.
If you're looking at some data sets, they're going to say a ferritin under 10 is low. But I've also seen data that says that to optimize for fatigue and energy, we're looking to optimize our ferritin to 100.
Yep.
The data I read was the 1 or 2 studies in women who are menstruating to get the ferritin to at least 50 helped with fatigue.
Yeah.
And you can have too much iron, so I typically aim for around I have a hard time believing that their fatigue is from iron deficiency if their ferritin is in the 40 to 50-ish range. Not to say some people don't feel better when it's even higher. So of course you could try IV iron infusions, which we've done for many people. I would say 75% of my patients felt their energy was improved. And then I have this percentage of patients, probably a quarter or so, where their energy was not related to repleting their iron.
I see it clinically, I see the cutoff be 30 for most people. Like, if they're under 30, it's making them tired. If I can get it over 30, even if it's like 45, which isn't optimal for different organ systems and whatever,
it's probably good enough
they're
for
gonna
energy.
feel better.
Yeah.
Yeah.
The problem is that, let's say, it is iron and it's under 30, but they can't get an infusion because of cost, because they're not too low for insurance companies to cover it. It's inexpensive. Like, I think going rate is somewhere between $400 to $600 if you're in a outpatient practice. If you're in the hospital, we're talking $700 to $1,000 per infusion. Easily. And so the problem with that is supplementing with ferrous gluconate or ferrous sulfate, which I think
hard to tolerate.
It will get the numbers up. In my clinical experience, ferrous gluconate and ferrous sulfate will get the numbers up, but they can't tolerate because of constipation.
Yeah, especially
I
our
took
patient
ferrous
population.
sulfate once and felt like someone punched me in the stomach.
Because it just sat there for like,
And
I don't
maybe
know.
didn't poop
No,
for a
it
week.
didn't. It caused severe pain, and so
Yeah.
I've had a hard time
It does
prescribing
work,
it.
though. For like people
does
with guts
see-
of steel, it does work.
and it does bring up
Yes,
their
I've
number.
definitely prescribed it to patients who they were like, I took it, no problem, and they did fine with it.
But then in my other piece of experience is prescribing the ferrous citrate or the ferrous bisglycinate or some of the more bioavailable quote unquote irons do not bring the numbers up.
I have seen them come up.
quadruple it. So I give it, but I'm doing 4 pills every other day.
Are they getting constipated?
No.
I haven't seen constipation with those. I have had to increase the amount. I find if we've done enough other stuff, the ferritin will go up. And if we haven't, or they just have a long-term inflammatory bowel disease or something, I agree. Like, it just hasn't been I have seen it work, but certainly not 100%.
If my patients can't get infusions or they don't want to get infusions or it's cost prohibitive or whatever, I'll say, like, let's try for like 3 to 6 months. Oral iron, 4 pills every other day of iron bisglycinate with, vitamin C or whatever to get it in. Don't take it with dairy. Don't take it with tannins. All of that. And I would say like half of people, I can get their number above 30.
Why are you doing it every other day?
It increases absorption. There's some data
There was a data set.
Oh, that podcast that we all listened to.
No, actually, I actually read the study.
Oh.
It kind of changed how people were dosing it. I just found I had difficulty with compliance.
To remember to take it.
Patients were not remembering.
Totally.
So what you're saying is, I think most of the dosing on those pills are about 25 milligrams per pill.
Yeah.
So you're going up to 100 milligrams.
Depending on their levels and if I have questions about absorption. for them. So if they don't have any gut issues whatsoever and I'm not worried about that, I'll do like 2 or 3. But some people I will do 3 or 4 pills.
Yeah, I think I'm not going high enough.
Well, I think the other challenge is we learned that iron's actually, it's not a good thing to give someone orally who has inflammatory bowel disease.
Yes.
Just for other reasons. So it's tricky. Infusions would probably be the best in that population, right?
Except for the cross prohibitiveness.
Right.
Yeah. And then the other thing is the cofactors. In my experience, you need, it has to be on an empty stomach with vitamin C and with B vitamins. Because the thing that I do see quite often is if the iron is within normal limits and the hemoglobin and hematocrit are even kind of within normal limits, you know, above 12.
They usually are, and the iron's ferritin's low.
Hemoglobin above 12, hematocrit above 37, but the ferritin is still really low. You need to remember your cofactors. That is where your B6, that is where your B12, B6, and I think folate help move it from circulation in the bloodstream into storage.
So maybe that combination product that one of our companies makes that's why it works well.
Yeah, I think it's got a bunch of products that have it.
Yep.
Yeah, I'll often use that product that we're referencing and then add on straight iron bisglycinate with it.
Oh.
So that I'm not quadrupling
all the
everything
other
else in
things
there. And it's a little cheaper for patients.
Which I think brings us to the second most important nutrient when we're talking about fatigue, which is B12.
Yeah.
B12, so one of the things that Dr. Kapadia taught me was forever I was only running methylmalonic acids. A methylmalonic acid is a blood test that tells us how much the body is absorbing methyl B12, right? It's an absorption test. If the methylmalonic acid is very high, the absorption is quite poor of B12, and you want to think about, starting injections. If the methylmalonic acid is very low, then you want to think about either A, overmethylating, or getting good absorption. But it's an expensive test. Vitamin B12 is a very cheap test. And I never used to do it until Dr. Kapadia talked to us, maybe on the podcast, maybe not, I don't know. And now what I'm seeing is it's a really good first line screening test. I'm using Dr. Kapadia's ranges, which is I want it over 400. I also don't get freaked out if it's flagged because I know it's not differentiating what they're taking orally or through the diet versus what they're actually absorbing. And so what I'll do is if their B12 is high, I'll follow up with a methylmalonic acid to see what's happening functionally.
It's a good idea. Yeah, so the lab cutoff is less than 400, but they even make note on the regular labs, less than 200 is deficiency, but less than 400 can cause symptoms in some people. So we definitely just try to replete if it's less than 400. I tell someone if it's above 400, but just barely, then it just gives me clues about their absorption. But I would say in 50%-ish of my patients, it's in the less than 400 range. So I think I found it to be quite helpful. And then you can easily follow it as well.
Yeah, I find it to be really diet correlated with people who don't eat animal products, obviously, but sometimes I can just bulk it up in diet and people do just fine if they're willing to. Or I'll just do like one round of a B12 supplement and they're good to go. And
then we should throw in the whole, B12 methyl B12 shots, which, it's not necessary to do shots. You can overcome pretty much any gut-related issue with oral supplementation based on the research I looked at, unless they have, part of their ileum has been removed, et cetera, with some of the patients with inflammatory bowel disease. And there are even sublingual B12 forms that they can use. But we do have a subset of patients that just feel better when they get B12 shots.
Totally.
And it's, it's hard to know. So I tell patients we can just do a trial if you want. You don't really need it more than once a month. But if you get this huge energy boost, we could do a series a little bit closer together and then space it out. But it's something that's worth trying in some patients with fatigue, because I have had this subset of patients that just, it must be something different that I just don't fully understand why they're getting that benefit, but they are. And maybe it's methylation related. Who knows?
And then also don't forget the atrophic gastritis or the pernicious anemia patients. Those people are going to be very dependent on injections, because they literally cannot absorb it through the GI.
Yep.
Okay, so that's a little bit on nutrient deficiencies. If we've done all of that and someone is still having fatigue, there's some sort of, one of our recent conferences, I liked how the presenter talked about like getting a 2-for-1. So if you have someone who's depressed and has fatigue, you could use Wellbutrin and they might get, an energy boost plus it could help their mood. So things like that, if they have fatigue and sleep apnea, of course, addressing the sleep apnea, it can be huge in affecting their daytime energy
Game
levels.
changer. Yep.
So, and then finally, you've gone through all of that. You've kind of repleted nutrients, tried to rule out any other medication side effects, and you've kind of done your full lab workup. What else can you do when someone's just tired, and you've kind of optimized whatever they can actually do for lifestyle and all of the other things we talked about? So in our world, we talk about adaptogens, right? So botanicals that can kind of help us adapt to whatever we're dealing with, whether that's whatever kind of cortisol pattern that is, whatever's going on with stress. So that can be helpful. I don't do a ton of testing with that. I tend to just try botanical adaptogens if I'm going to try it with patients.
So let's just list them. My list is ashwagandha has great data, erythrococcus, Siberian ginseng, rhodiola. Those are what I use more. Licorice.
Yep.
I really like rhodiola. I use that a lot.
Yeah, that's pretty much my list too, and some of the combination products that have a couple of those in them. And
I also think, from a herbalism perspective, there are also, constellations of patients that do well with like rhodiola versus ashwagandha.
Totally. Yep.
Yeah. Like the way I think I mentioned this on the podcast before, but the way I was taught to use rhodiola is a plant that thrives in the coldest, most, acrid environment in Siberia. It's Siberian ginseng. And so if your life is a living hell, like you're in the stress of it, you're in the thick of it, rhodiola is the plant that I would use for that. Ashwagandha seems to be really good if you pulse it. Like a little bout of stress now, a little bout of stress later, you use it while you're in the stressful situation, and then you kind of pop off of it.
I also it's not an herb, but L-theanine I see help a lot, especially for those anxious, wired but tired folks, because it just kind of
sound fun.
No, totally.
But it's definitely a consolation.
Yeah, and it just brings it down so that they're not burning so hard throughout the day.
And that's that. For me, I'm like, okay, that's that anxiety patient,
and
who
it's in
can't
green
turn it
tea.
off.
So if you are going to have your caffeine, throw in some green tea. And then we talk about mitochondrial support with Dr. Gurevich. I feel like you enjoy this topic.
I do. This is my favorite topic.
So I want you to talk about how you are deciding when you might give someone an adaptogen versus mitochondrial support.
Mitochondrial support is expensive. So I'm generally going to start with adaptogens.
Okay, let's say there was no cost issue.
Oh, great. Okay. So let's just talk about mitochondria.
Okay.
So mitochondria is, as we know, the powerhouse of the cell.
I've heard that before.
Yeah. I will say I do think that my guess is in the next 5 years, we are going to figure out that mitochondria is not one thing. It's like 14 different things.
Yeah.
Because it seems like mitochondria... So we used to think, I'm going to back up a little bit. We used to think mitochondria was the battery pack of the cell. Now we actually think that mitochondria is the motherboard of the computer. It seems to control...
I haven't heard that word in a long time.
No.
Bringing back computer lessons in high school.
Welcome to the 1990s. You're welcome. It controls hormone secretion. It controls redox reactions. It controls immunological systems. It controls ATP and energy production. It does a lot, and we are only starting to learn about it now. We also know that we can boost mitochondria by fasting. Fasting boosts mitochondria, by ketogenic diet, because that's a form of fasting that boosts mitochondria, and by actually supporting the nutrients that support mitochondria. So there was this really, really great study that I cite all the time that was done with chronic fatigue and MSCFA. What's it called?
MECFS.
MECFS patients.
Same thing as chronic fatigue.
But also Desert Storm Syndrome patients. So Desert Storm Syndrome are these soldiers.
I remember I saw this study. Maybe you sent it to me.
Yeah, it was like a 45-person study. So it wasn't massive, but it was enough. And they took these chronic fatigue and Desert Storm patients, and they randomized them to either receive nothing or receive this conglomeration of nutrients. It was like NADH, CoQ10, alpha-lipoic acid, acetyl-L-carnitine, like all of those things that we think that supports mitochondrial function.
Right.
And what was documented with that subset of patients that received the support is increased quality of life, increased subjective feelings of energy, and increased productivity. We also know that the place that has the most mitochondria in the whole body is the intestinal tract, because that is probably the most active part of your body. Like even more active than your brain is your GI and digestive process. So sometimes if you spoon feed the body mitochondrial support in this conglomeration of nutrients, you see a significant improvement in your energy. You interestingly will often also see a reduction in bloating and a reduction in brain fog. It's really it's like.
So it sounds like this is a much more sort of impactful intervention than an adaptogen most of the time, would you say?
If it's the correct intervention.
Yeah,
which
when
you
would
know
you
by-
decide to give it?
Honestly, it's not where I start.
Yeah.
And honestly, it's not where I start mainly because of cost.
Yeah.
But you're looking for, these patients who have mitochondrial defects, first of all, anybody on chemotherapy or really strong pharmaceuticals, most likely it's impacting their mitochondria. So that's a little bit of a no-brainer. Anybody with neuropathies, where you're seeing long-standing neuropathies distally, then there's a potential that it's a mitochondrial issue. I also think about mitochondrial support for gastroparesis patients, for where motility is not working.
Nervy stuff. Yeah.
Yep, I'm gonna give them mitochondria. Chronic brain fog. I think about this. The reason why it always starts. I think for all of us, it always starts with the patient. You see a patient.
Yeah.
And I had this patient, and I did everything for her. I mean, first of all, she worked with a really good naturopath before her. The naturopath stalled out, so she sent her to me. And then, I treated her bacterial overgrowth, and that didn't get us anywhere. And then I went after I did a stool testing, and I treated her biofilms, and that got us somewhere, but it didn't get us everywhere. And her big complaint was chronic bloating. And then I was like, you complain about chronic bloating, plus you complain about fatigue. She's like, before I got sick, I could walk on the beach for hours. And now I have a push walker that I have to sit after 10 minutes. She was stalling out of life.
Yeah.
And I had just listened to a podcast, that's how I absorb my content, about mitochondria and what it does. And I was like, let's try this.
Yeah.
Let's try this. And we started, I require 3 months. It's a pricey intervention, but I don't want to give up on it until it's been 3 months.
Yep.
And so I started her on it, and she was like, oh my God, I cook dinner for my whole family.
Wow.
I haven't done that in 4 years.
Yeah.
She's like, me and my husband went for a walk on the beach, and he was sitting, and I was like, no, let's go. And my bloating improved by 40%.
Yeah.
And so then I started looking at it's kind of like when Dr. Kapadia taught us about the allergy episode, the allergy and IBS. It changed my practice
For GI
for
symptoms.
GI, yeah. Or
if they have fatigue and GI symptoms.
Yes. I'm like, this, I need to try this.
Yeah.
Yeah, I mean, it seems like even if they have suboptimal absorption, like a lot of people, it's worth trying because we pack so much into these combo products that if they're getting some of it, and if it's working locally too, it sounds like it's just something to try if someone has fatigue in general and you've kind of exhausted all of the conventional and sort of botanical first trial options.
Do you keep people on it, or do you pulse it?
So 3 months minimum.
Yeah.
Probably I'm going to go a year. And then I'll start pulsing it as they need.
Wow, a year continuous.
Also, you know who else? Post-COVID, long COVID.
Totally.
Also, Lyme disease patients, tick-borne illness patients,
Athletes,
Epstein-Barr patients. I think that there's a couple of things going on. I think just nutritionally within our diet, it's
hard to get.
I mean, especially if you're eating a regular standard American diet.
Yeah.
And who can really eat those amount of vegetables we're telling people to eat? I'm like, how many meals a day? I can't get it all in.
So who you're talking
We're doing
about?
2 meals a day here.
So who you're talking about in particular, who started, I don't know if she started this research, but she definitely publicized this research, is Terry Walls, who studied mitochondrial support for MS.
I can't do it. I would.
She requires, I think, 3 cups of greens and 8 cups of vegetables.
Oh my gosh.
3 cups of cruciferous vegetables.
I mean,
Yeah.
we'd probably all
And a
feel
cup-
great if we could manage that.
Or terribly bloated.
But how
Do
can you eat
juices
that much
count?
food?
No, juices do
That's
not
the
count.
quantity of food. I'm just
What
like,
about green powders?
They do not count. I will also say my experience with green powders is generally, there's
don't
everything
know.
in there,
Oh,
but not a
man,
lot of anything.
They are having a
knows?
time, though. All
Yeah.
my patients are asking me about green powders, and they are making a killing.
Yeah,
That is the business
and
to be
I
in.
keep on being like, there's enough in here. There's enough ingredients. God knows
know.
there's enough ingredients, but there's not actually enough nutrients in it.
And also, most of them aren't organic, and it's super condensed pesticides. And they're
I
stupid
agree.
expensive.
I agree with everything you're saying.
Great ingredient list.
Yeah, great. It looks like it has
Great
everything.
label,
Yeah.
beautiful branding.
Also, they have lots of marketing dollars.
Yeah.
Yep.
I know.
So,
there's pea protein in it, so it's out for me, and I just cross it off my list.
so that is the mitochondrial deficiencies in the GI have kind of been a game changer. I might just put together a data set if I ever write this presentation, just about mitochondria in the GI, because when I pull data on it, when I was thinking about writing a presentation, there's also data specifically about chronic bloating, chronic IBS-like symptoms that are being caused by mitochondrial deficiencies.
I mean, yeah.
Would you consider using it in a gut recovery protocol?
It's such a great question. Yes, I will say I don't know.
Celiac recovery?
I don't know if I would use it stock because there's also a subset of patients who do not tolerate it. Like I have this one particular family where I treat the dad, the mom, and the kids, and fully grown kids. If I give them too high of a dose at the mitochondrial support product, they'll vomit.
Huh.
Yeah,
I feel like I've seen that actually. Now that you're mentioning that.
I wonder which piece it is. I haven't seen that with the individual ingredients that we use.
I never do individual ingredients because it's so much cheaper.
But in the past we've done, carnitine, CoQ10, this type of a thing.
And those also there are studies saying that's good for vomiting. Cyclic
vomiting. Oh, yeah, there are. Totally.
So what the heck is going on?
Cyclic vomiting. We need to add that to our list. That is a great topic.
I have plenty to say on that one.
Yeah, that's a great
topic.
Well,
so back to mitochondrial support. It seems like it's worth trying in fatigue that's sort of recalcitrant to other interventions.
Yes.
As well as concurrent fatigue and GI disorders, which is most of our patients and most of the country.
And I will say it is actually my first line therapy for long COVID, chronic Lyme, which I don't treat a lot. I usually put them on mitochondrial support and then punt. And then like Epstein-Barr chronic viruses. That is actually my first line of defense for those people. And also recent chemotherapy use.
That makes sense.
And radiation.
Yep. Okay, great. And then I wanted to briefly talk about histamine. So I've had patients since we've been treating mast cell the last 5-6 years, they will feel like their fatigue is amazingly better if they've cut down on histamine foods, which again, I don't recommend excessive diet.
Yeah. Oh my God.
This I don't ask people to do this outside of a couple, like if they're eating like a jar of kimchi a day or something. But
doesn't it include chocolate?
I don't.
And any
I
leftovers?
Can't live without chocolate at this point. So I don't.
Can't either.
Chocolate, caffeine, and
why
IPAs.
Would we?
Those, you're really taking it.
Yeah, no. I'm like, how do you get out of bed in the winter?
We're gonna leave you the baby, but the chocolate and the IPAs.
I don't take people off those things, Rebecca. But some people come in saying they've taken themselves off,
and they do feel better,
and they feel like their fatigue is better. So it's a good tip off for us that addressing histamine in other ways may help their fatigue, because it can cause, antihistamines can cause fatigue sometimes if you pick the wrong one for that patient, but just consuming excessive histamine, if the person isn't breaking it down correctly, can make them tired. So that's just another little...
And this, I think, is a really good reminder of also the antihistamine drugs.
Right.
Are also the problem with the histamine.
Didn't we do an episode on that? Okay, I can't remember. I don't know. Did we do it? Okay. Well, we'll either do one or maybe we'll refer back to one that we did. But there's lots of interventions you can do, and not all of them will be sedating for each person. So a tip-off if histamine's affecting them is if they get really sleepy after they eat. We had a friend that said that was a sign of a good meal, but you don't want to be falling asleep after every meal.
But that also could be a sign of
excessive carbohydrates, overgrowth. So just in addition to thinking of dysbiosis and food allergies and all the things, it could just be histamine, and it might not be that they're allergic to everything they're eating.
Yeah.
Yep.
Very tangentially related, because the group of us were talking about this earlier, is progesterone.
Right.
Mm-hmm. And a relative deficiency of progesterone or estrogen excess, which is a debated term here, might also cause more fatigue in people.
Through a histamine potential pathway.
Potentially. Yeah.
Interesting.
Yeah.
Yeah, because that's the other thing. We didn't even talk about cycles. Hormonal cycles can affect your energy.
We were going to come back to that. So I don't know if either of you wants to talk briefly about, we might need a whole episode on
Everybody's
that.
looking at Dr. Sand for a quick recap. She happens to be our
the
women's
last
health
thing,
expert.
well, if you don't want to we don't have to dive into that today. We could talk about the effects of, we have a lot to talk about with hormones and PCOS in our 25-part series coming in the fall.
But just keep it on your minds that hormones and fatigue,
they're related in some way.
There.
Okay. And then finally, just in our world, frequently I refer patients for acupuncture, body work, nervous system work, which can have profound effects on fatigue, again, if that's the right modality for them. So,
back what you were saying about people being overworked and racing too hard throughout their day.
That never happens.
Yeah, it's so rare. A spiel that I give folks, a lot of my patients, is we have a very old hardware. Our brains are old hardware. And think of it as way too many tabs open in your browser when we have every time we drive anywhere, we're listening to a podcast. No one in particular here, but me too. But everything is constant input all the time. So being mindful of closing tabs throughout the day, or just being in silence, looking out the window, allowing space in to just let your nervous system be a nervous system. And when we think about animals that we see, 80% of their time is spent just staring at something. we were kind of designed to do something similar.
That is such a good reminder.
How do you do that and 10 hours of work on the computer every day is the question.
I don't, but I really encourage others.
So I was telling everybody I was camping this weekend on, and like, there's something about camping where you don't have service, you know, or it's kind of not socially appropriate. At least I don't think it's socially appropriate to be on your phone.
Totally.
But you're like outdoors in the shade. Like for me, that's like my reset, and I come back so better rested.
Yeah. We should do that every weekend.
That was awesome. That was a really good deep dive. And I think that took us lots of different places.
I thought I kind of knew fatigue, but my differential is now like a lot bigger.
So we started by talking about mood issues like depression and anxiety, which we know, but also ways to support it using adaptogenic herbs. We focused on different options. We talked about testing that we can do, B12, ferritin, how to optimize different treatment strategies, IV versus oral, methylmalonic acid. And then we jumped into mitochondria, which is like...
That blew my mind. I mean, I guess I didn't know about the gut and the mitochondria, but I can't wait to start using that for folks. So cool.
What else did we cover? Is that everything we covered in this episode?
I think that's everything that you need to know about fatigue.
And I like the shout out for the nervous system, acupuncture, like, you know,
body
really
work.
You never know what's good. I guess you never know what's going to work for someone. So if you've done all the standard things, it's a bit of trial and error, but try some mitochondrial support, refer them to someone who can do hands-on modalities. It's just, we've had amazing results with different things for different people. And sometimes you just never know what's going to work for someone.
I agree.
Shop around.
Thanks, guys.
Bye.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.